So welcome everybody to this downloadable session of the 2020 International Dementia Conference. We're here to talk this afternoon about the Specialist Dementia Care Program. My name's Steve Macfarlane. I'm Head of Clinical Services for Dementia Support Australia. This is my colleague Arsh Katoch.
I'm Service Manager for DSA Program and just looking at providing support and guidance through the service. I guess, Steve, given that the session is around reflecting on the first 12 months, and given that we now have 10 SDCPs nationally, maybe we want to start around reflecting on how did the services start?
How did the whole network really of dementia support services in Australia start? I suppose, Arsh, we have to go back to 2007, and the Commonwealth government at that time introduced funding for the Dementia Behaviour Management Advisory Service, or DBMAS program. It was set up at that time in each of the 8 Australian states and territories under a different provider. And it wasn't until 2015 the next branch of service provision came in, and that was in the form of the Severe Behaviour Response Team, which came in towards the end of 2015. In mid-2016, in fact, at this very conference some 4 years ago, the then Health Minister Susan Ley announced the first funding for the Specialist Dementia Care Programs. In late 2016 then, we had the National DBMAS service put out to a single Commonwealth tender. So a single provider would provide the services instead of 8 different service providers, and the partnership led by HammondCare won the tender for the national DBMAS, and at that point the Severe Behaviour Response Team and DBMAS were brought together under the umbrella of Dementia Support Australia. The funding that Susan Ley announced in 2016 finally resulted in the establishment of the first pilot Specialist Dementia Care Program at Brightwater in Perth in September 2019, I think it was. So that's been running for just over 12 months now. And we're at the point in time now where about 9 of these have been rolled out nationwide.
Yep. And that kind of shows the journey from the start to where we are now. Given that the SDCPs are quite a rare resource and a new resource, there are some clear objectives that the department's also outlined. Do you want to maybe talk a bit more around those?
Sure. I mean, the SDCPs are targeted really towards a very narrow band of people living with dementia who have specific problems that meet specific criteria. Certainly it's true that the vast majority of people living with dementia in residential care will have some degree of behavioural disturbance at some point during their stay in residential care. But the SDCPs are really targeted towards the people at the very top of the pyramid of need, if you like, and we'll talk about the Brodati triangle shortly, but people who have really very severe behavioural disturbances that arise primarily as a result of their dementia and not any other comorbidities. And not only are these units targeted towards people with those very severe levels of need, but also where the need has been refractory to adequate management by other specialists. We know that people move up and down between the tiers of need on the Brodati triangle. They don't necessarily occupy them for prolonged periods of time, but the SDCPs are targeted towards a group of people where significant effort by specialist services has already been put in to try to manage the behaviours, but without success. So it's for people whose behaviours have been refractory and very severe for quite a prolonged period of time. And the whole intent being that the SDCP provides a transitional accommodation, a space within which the behaviours can be adequately addressed and the person's quality of life maximised, before then being transitioned back to a more generic residential aged care environment. So they're not permanent accommodation, they're not intended that way. They're a very scarce resource, as you've alluded to. So if they're all filled up and people stayed in them forever, they just become a lost resource that couldn't be accessed because people didn't move through the system. So throughput and ongoing ease of access are key pillars of the system as well. We do allow people with medical and psychiatric comorbidities access to the SDCP as well. They're certainly not excluded, but the behaviours for which the person's being referred must primarily arise from the dementia and rather than from any of the psychiatric comorbidities.
Yeah. So definitely the transitional nature of the program is the key in ensuring that people who do access the program, they remain in there for 12 months, and then that at the end of that is when it's reviewed. And you alluded to the Brodati triangle. So where does the SDCP fit into that in terms of the service delivery?
Okay, well, the sort of 3 planks of the Commonwealth service delivery program encompass the 3 roles of Dementia Support Australia. The National DB MAS service, Dementia Behaviour Management Advisory Service, that exists to manage the lower tiers of behaviour, so people who are at Bradati tiers 3, 4, creeping into the lower end of 5. Severe Behaviour Response Team is funded to look after people who are in residential care towards the more top end of the triangle, so tiers 5, 6 and 7. And the Special Dementia Care Program is targeted at that refractory group where the behaviours haven't been able to be adequately managed by other services who require longer term specialist input in the form of the specialist multidisciplinary teams that are found within the SDCPs.
Yeah, so I think as the Bradati triangle suggests, that people sitting in that tier 6 is quite rare, so less than 1%. So for the program to be catering to the people that do actually need it, the eligibility criteria needed to be quite strict. So maybe we talk a bit around the eligibility criteria, with the first one being that it is primarily for people where the behaviors are stemming as a result of dementia. And I know we've had a point of contention around that as for the whole year, where we've done lots of roundtable conferences around this as well. Do you want to touch base on that in terms of some of the discussions that have come forth on that?
Sure, a lot of the discussion is centred around the fact that in some classificatory systems in psychiatry now, the word dementia doesn't actually exist. It's all been subsumed into this concept called major neurocognitive disorder, which merely requires that a person has acquired a cognitive impairment of sufficient extent that it interferes with their ability to function on a daily basis. So it could include technically a cognitive impairment that arises from long-standing schizophrenia, from an acquired brain injury, from even a hypoxic birth injury. So I think it's wrong to assume that a specialist behaviour management service has expertise in managing behaviours that arise from any cause. The expertise of the SDCP program is in managing behaviours that arise from dementia, as it has been traditionally understood in terms of a progressive neurodegenerative disease that can be expected to worsen over time. It takes a special skill set to manage behaviours that occur in that context, and it's really quite different to the skill set that might be required to manage significant behaviours that arise in the context of intellectual disability or schizophrenia, for example. So we're very much trying to build up the expertise in the management of dementia as the term has been traditionally understood in these units, rather than all-cause cognitive impairment. Again, if you look at younger individuals who might have suffered a catastrophic brain injury, although sadly there is no right place for them in the Australian residential aged care system, SDCP is not the right place either, because those deficits can be predicted to be enduring, and once in an SDCP bed, that would continue to be occupied for potentially many decades. So again, a very scarce resource. It's going to come to about 280 beds or thereabouts once all of the units are commissioned, once all 35 are opened. And if you still take the fact that the units are targeted towards the top 1% of people in the Bradati Triangle, with close to, 450,000 people in Australia living with dementia at the moment, 1% of that is 4,500 beds just of people living with dementia. So it's not going to meet all of that need, and therefore very important that people do get into the beds, the targeted group for the program.
Yeah. So I think around the dementia diagnosis bit, we've had a lot of questions, especially from regional areas where diagnostic services are not as readily available. So does the person need to have a definitive diagnosis of dementia to access the program?
No, I mean, common sense comes into the equation, I think, at some point, Arsh. Certainly if the history is of somebody who's in their late 80s, for example, who's been in residential care for 5 years, has declined in terms of their observable cognition, function and behaviour over that time, and has no known psychiatric comorbidities, we certainly wouldn't insist that a person in that group with that demographic description be sent off to a specialist for a formal diagnosis. We will accept common sense where it exists. I guess the areas where greater diagnostic precision is required is in particularly those younger individuals who have multiple medical and or psychiatric and neurological comorbidities, where the cause of the behaviour is often a lot more difficult to identify. So we take a very close and careful history of the people who are referred for assessment for eligibility into the program to try and ensure that the behaviours do best reflect the dementia rather than anything else that might be going on.
Yeah. The second eligibility criteria, obviously being around intractability, so demonstrating that a specialist or a specialist service has actually had input in supporting the person with dementia and has not been successful. So do you want to expand a bit more around what does that actually mean?
Sure. I mean, this is in recognition that people do move up and down between those levels on the Brodati triangle. Certainly people can have very, very, very severe behaviours that arise as a result of a delirium, for example. They can promote themselves temporarily into tier 6, but we wouldn't admit a person with delirium into the SDCP because we can predict that the delirium will resolve, and when it does, the behaviours will decline as well. So the behaviours need to be reasonably long-standing rather than just something that's arisen in the last couple of weeks. And we need to try and ensure that the people who gain access to the beds have already passed a number of hurdles to get that far, and the hurdle is that a specialist service, not necessarily DSA, though it could be DSA, it could be aged psychiatry or geriatric medicine outreach, either public or private, but that someone with a degree of expertise or some organisation with a degree of expertise has already tried to manage these behaviours, and that management, despite being faithfully implemented, has still not succeeded. So it's the refractory group having passed through that filter who are felt to be suitable as the second eligibility criteria.
Yep. And I guess the last one being around severity. So mentioning earlier, as you said, that it sits on tier 6 on the Brodati triangle, which is for severe to very severe behaviours. What does that actually mean for referrers who want to know what does very severe to severe actually mean in terms of
Well, look, I guess severity is in the eye of the beholder. I don't think we've had a referral through either of the DSA programs where the referrer hasn't felt that the behaviour was severe. That's why they're referring them. But as part of the process of developing eligibility criteria for entry into the program, we've developed assessment tools to help us determine objective criteria around severity. And I believe you're going to tell us a bit about those tools shortly as part of the learnings that have come out of the program in the last 12 months.
Yep. So I guess one of the key in terms of the role that DSA plays in the SDCP is providing the needs-based assessment, which assesses eligibility into the SDCP program. So we have an assessor who goes out, conducts the assessment, but also provides, once the client is assessed as eligible, provides in-depth presentation to the clinical advisory committees around our assessment and the conclusion in terms of the eligibility for the person.
Sure. I guess there's a number of steps to getting an assessment completed. We first ask that people undergo a triage process over the telephone or referral via internet or fax. Once the triage process has been conducted, an assessor attends on site. They then construct, as you mentioned, really quite a detailed report, which then gets reviewed by one of the medical specialists within the DSA program, just to see that the assessor's thought process about determining eligibility is in fact valid from a medical point of view. Once we've actually determined that DSA feel the referral is eligible for SDCP placement, we then provide the clinical advisory committee of the SDCP in question with the report, and we can present the report to them if required. The pile of accepted referrals that the clinical advisory then considers is their process to sort through in terms of prioritising the need for the allocation of the next bed. So the involvement of DSA really, if you want to put it that way, stops once we have briefed CAC about the referral being eligible or not. It's then the CAC's responsibility to process the accepted referrals and prioritise them for entry into the program.
True, and I think at the time whilst the client is waiting on that wait list to be assessed as suitable for the SDCP, DSA continues to provide support if they're involved while the client is on the wait list. But also, I think keeping in mind what we have seen quite often, that DSA gets involved at the same time as a needs-based assessor goes into as well. So we either start commencing our support through SBRT if there's no specialist support that's been there. So we've seen scenarios where SBRT has been on site prior to the NBA assessor getting on site as well, and they work collectively in terms of supporting the client, where one is looking at more hands-on strategies, whereas the other one's looking more at the eligibility criteria into the SDCP. Sure,
with the limited number of beds and the limited number of units that are operational as we speak, there are going to be people who will have to wait a period of time despite having been deemed eligible, and it's important not to leave that group hanging in terms of a lack of support from specialist services whilst they await that placement.
Yeah. So I think other than the development of a robust process around the needs-based assessment being one of the key learnings for us, which we got a lot from the DSA, from DBMS and SBRT, the second thing was, as you mentioned, around how do we assess severity? And severity is very subjective because it really depends on the carer, whether they're in the community or whether it's a carer in a residential care setting, or even a carer who is supporting a patient in an acute health ward, where they might actually be more prone to seeing severe behaviors on a regular basis. So their idea of severity becomes more normalized compared to someone in the community, where it might be their first experiencing observing those behaviors.
Which is why the importance of an objective tool to assess severity really comes to the fore. And I guess the tool that we've developed, it relies on three different key components, doesn't it? There's the inherent nature of the behaviour, whether the behaviour could reasonably be assumed to denote a level of risk. And, key amongst those top behaviours that have prompted referrals to SDCP are aggression and agitation, because it's easy to see how aggression can result in physical harm. So we look at the inherent nature of behaviour itself, the consequences of that behaviour, whether in fact anybody has been significantly or even not significantly hurt or damaged by the behaviours, have there been consequences to the staff. And we also look at the likelihood of the behaviour recurring. And it's important to take all of those three domains into consideration, because it's quite possible to have, for example, a trivial behaviour that occurred once, somebody bumping into another resident in a corridor, that had a tragic outcome in terms of death, but it was a one-off accident despite the consequences being severe. So we not only take into account the consequences that have occurred, but the frequency of the behaviour, which leads to the likelihood of it recurring again, and we take into account the impact that it's had on the environment and on staff. So very important to make that holistic assessment of need in determining SDCP eligibility.
Definitely, I think that impact on staff was one of the key learnings which we found quite early on, which was missing from the tool, and we had to add that in terms of the stress on the carer, not only in the community but in residential setting as well. And then looking into the acute, whether they are able to support the person with one carer or do they require more than one, and in some scenarios even requiring access to security to be present when they're providing care.
Yeah, those are a couple of things that we take into account when we are assessing cases that come to us from the acute hospital sector. I think that hospital services sometimes have an unrealistic idea of what SDCP is and what it can do. Essentially, they are nursing homes, but are resourced at a higher level than your typical home, and with particular expertise in behaviour management, but they are not places that have security. They're not gazetted under the various state and territory mental health acts, and somebody who's requiring a constant one-to-one security presence in a hospital, which is a very well-resourced environment, and requiring, for example, multiple intramuscular injections and psychotropic chemical restraint for their behaviours, they're probably sitting at tier 7 at that point and wouldn't be considered appropriate for SDCP until they've become somewhat more settled than that and their needs for care have become lower.
Yep. And I think the fourth domain that we look in terms of the risk assessment is around strategies in place as well. So looking at raw or residual risks. So whether the carers have any strategies in place that are reducing the risk of the behaviour from occurring on a daily basis to maybe once or twice a week, or they have no strategies in place, or they are strategies but nothing is actually working at all, which again increases the risk quite significantly.
Yeah, those concepts of raw and residual risk are pretty important, and we added those in a bit later to our risk assessment tool, because we realised that sometimes the inherent nature of the behaviour could have been really quite risky. There could have been a physically robust younger man who was making decent attempts to punch people's lights out, but fortunately no severe consequence had happened. It doesn't mean that it wouldn't happen, but the inherent nature of the behaviour suggested that it was a likely outcome. So in those cases, even if there had been no actual injury to staff or to property, we'd still give a rating for the presence of that obvious raw risk, which we modified somewhat and called residual risk, if the home or the acute setting has put strategies in place to somewhat decrease the risk of that behaviour. So it's quite a complicated algorithm, but quite elegant. And we've been through quite an extensive process to try and validate it within the Brightwater pilot unit that opened up last year, and also on an ongoing basis in the units that have been commissioned throughout 2020.
Yep. And I think some of the other learnings have been around having that collaborative approach around coming to that eligibility outcome as well. So the consultants not only, once they've completed their assessment, have a discussion with their peers that they've got access to nationally. They have discussion with myself, but also they have discussions with you as well, where they present the case to you. And I think you've probably reviewed every single client that's gone through the needs-based assessment program so far.
The vast majority of them, I think, Arsh, yeah. But I do have a backup, and we do have other of our medical specialists within DSA trained up to assess these needs-based eligibility assessments. But, you know, having gone through 12 months of the process, I mean, I'll ask you now, I mean, how many of these have we done? How many have actually been accepted for eligibility into the program, and how many do you know have been placed at this stage?
Yep. So even though it's only been a year, we have been quite busy. So we've had over 200 referrals for needs-based assessment into DSA, out of which 161 actually progressed to an on-site assessment. The clients that didn't progress to the assessment, we found that it was either because the family withdrew consent after we had gone through the triage process, or the client's behavior had actually settled, and the referral was made as a measure of finding an alternative placement for the person. We've also had scenarios where the behavior has escalated quite significantly and they no longer required SDCP support because there were some acute issues that the staff in the hospital wanted to address.
Okay, so 200 odd referrals, about 165 of which have made it through the actual assessment. And of those who have been assessed, how many have been found eligible?
95. So we've had 95 clients who were assessed as eligible across the country. So of course, with the SDCPs that have been in first one, as you mentioned, the prototype in Western Australia. Following that, we had one in New South Wales in the Newcastle region with HammondCare Cardiff, and then one in Melbourne in HammondCare Caulfield. Following that, we had one in Adelaide with Aldersgate, and then we've had 3 up in Queensland. So starting from the top with Good Shepherd in Mackay, then 2 in Metro with St Martin's with Anglicare, and Alzheimer's Queensland in Brisbane. And then we've had Ebre through Uniting in ACT. So these have been the ones that have been opened. And more recently, we've also had 2 others come up in Melbourne. However, the openings were slightly delayed again because of the stage 4 restrictions that happened in Victoria.
Love stage 4. So about 200 referrals, 165 got assessed, 90 or 95 were eligible. How many are actually in situ in the units as we speak?
So at the moment, we've had 49 clients that have been placed in the different SDCPs, and out of those, some have already been discharged back into mainstream residential care as well. So what we've seen is that out of those, a client has to wait an average of 56 days on the wait list before they get placed. But again, keeping in mind it's an average across the nation, so the range can be either a few days to several weeks to a month. That's why the average is sitting at 56.
So what do you mean by on the wait list? Is that the delay between the referral first being made and them getting a place, or is that the period between us providing the clinical advisory committee approval or eligibility for placement and then a placement occurring?
Yep, so the latter. As you mentioned in the process earlier, so once a DSA assesses a client as eligible, we provide that outcome back to the referrer, but also to the clinical advisory committee. And then it's up to the clinical advisory committee to get all the members together to distribute the report to them so they can have a read and then arrange a meeting for us to present the client and discuss, and then they assess suitability, which kind of from the discussion so far, having been on all the CACs across the country, really ranges from looking at the other resident mix as well in terms of what the behaviors are. Is this person going to be a trigger for another resident, or do they feel that they can support this person? So once they make that suitability decision, or until they make that decision, the client remains on the wait list, because after they've made the decision around suitability, they go out and do a placement assessment. And following that is when the placement occurs. And once the client moves into the SDCP, that's when the episode with DSA closes. So it takes all those days into account for being on the wait list.
Okay. And I suppose with a number of assessments having been done now, are we in a position to paint a picture of what a typical SDCP client would look like? I mean, we know about their level of behaviour severity, but are the people who are eligible, are they more likely to be male, female, older, young types of dementia?
So again, even though again it's been only a year, but from the data that we've collected, we find that an average person going into an SDCP or being referred for the needs-based assessment is a male client at an average age of 75 years, residing in a residential care across Australia with Alzheimer's type dementia. Mm-hmm. And most likely about 80% has been supported by DSA, mainly SBRT. And the main reason for which they're being referred is physical aggression, which is predominantly during personal care, but it is in the form of either hitting out or kicking, punching people. So that's the average of what we've seen. And then we've also started comparing that with the other services within DSA, so DBMAS and SBRT. And what we found interestingly is that the DBMAS service caters predominantly to female clients. When we look at the men in DBMAS that it supports, we're only looking at 43% of men that get supported through DBMAS, but they're a lot older, so they are at an average age of 84. And the main reason for which they're being referred is agitation.
So I guess that relates to how DSA triages the risk of the behaviours, the same degree of behaviour that's occurring in somebody who's 85 and frail doesn't pose as much risk as the behaviours occurring in a person in their late 50s or early 60s?
Yeah, because interestingly, we saw that with SBRT, the number of males being supported increases dramatically, and the age goes down to get sitting around 80 years, and the behaviour changes from agitation to physical aggression. And when we've taken that into needs-based assessment, we've seen that the age drops even further to an average of 75 years. With physical aggression being the main behavior, and close to 70% of the referrals into needs-based assessment are for male residents.
Yet the commonest form of dementia that people approved for SDCP have is still Alzheimer's disease.
Yes.
What proportion of the total have Alzheimer's?
So I think we're looking at close to 75 to 76% of clients having Alzheimer's disease as the main type of dementia.
That warrants their assessment and placement into SDCP. Okay, that's interesting.
The other thing we'll be looking at is how long has it been taking for us to do the process? Because again, as we explained earlier, the process starts from the point of triage to on-site assessment to review, then presenting it to the clinical advisory committee for their suitability assessment. So we've talked a bit around how long it takes for someone to wait on the wait list. But on an average, what we've seen is that the triage can for what we have to do is within 7 days. On an average, DSA has been taking 4 days. And again, when we've gone a bit deeper into that, why is there been a slight delay? A lot of the time it is mainly to do with the fact that the consent hasn't been obtained for us to complete triage.
Yes, which takes me back to an eligibility criteria that I should have spoken to you. It's really important that prior to making any referral for assessment for eligibility, that the person who is responsible for providing consent, the authorised decision maker, agrees to such a referral being made. So we've experienced a delay there at triage.
Yep, because the verbal consent wasn't provided. And then when we progress to assessment, which should take place within 14 days, we're actually averaging at 7 days. And again, when we've seen what the delays have been with that, again, it's been around getting the written consent from the family, where the verbal consent was taken but written consent hasn't been sought, or there's been delays in terms of organising the visit. Once we've conducted the visit, the next part of our process is reviewing all that information, collating it into a report, which for us should be taking 21 days, but we've actually been completing that in 11 days. Okay. And some of the delays in that, again, has been because we're finding it challenging in accessing documentation for the clients, especially in the acute setting, where due to privacy laws, we can't access the information as easily. So that's resulted in delay of information coming through, which means that for an assessor, it becomes very challenging to show whether the client meets certain eligibility criteria.
So there's a lot of detective work required as well, but we're sort of meeting those targets. I guess at this relatively early stage in the program, with only 9 units currently open, things will get busier for us as more units come online, and it might get harder to meet those targets, but we seem to be on track for the moment.
Yeah. Definitely. I mean, we've so far, the other thing that we've done is all of DSA consultants and workforce is trained in assisting with triage. Our SBRT workforce is trained in doing the on-site assessments. They've gone through quite thorough workshops with us, where we've also taken the advantage of giving them placements in some SDCP-like environments where they get a sense of how a client is supported by carers in that environment, what behaviours do they need to have so they can be supported. We've had, between you and myself, several discussions and workshops with them in training them with the tools. I have my regular catch-ups with them, and again discussing some of those very peculiar scenarios where they've had to do a lot of investigation to find out what the client is eligible. And I think as a team, there's a lot of discussion that comes out of that, because being a very new program, there's lots of learning as we continue with the service.
And look, I can imagine that anybody referring a client into the program would do so with the expectation that they might be accepted, the likelihood they might be accepted. We do have an appeals process if people disagree with the outcome of the needs-based eligibility assessment. Are you aware of anybody having appealed thus far against decisions?
So luckily, we've had no appeals so far. It's been a year, but the information is on our website in terms of what the appeals process entails and what's the time frame for us to get back. But so far, we've been lucky that no one has appealed the decision, and especially if we've assessed someone as ineligible.
Okay. And I guess in terms of making a referral, you've mentioned the DSA website already. So people can either lodge a referral online, they can call the national 1-800 number, or make a referral by fax on the relevant forms from the website as well. Is that correct?
Yep. And the only other option is sending by email to us as well.
Okay. Well, look, Arsh, I think the time allocated for the discussion has expired. It's been a pleasure getting together to talk with you about the SDCP program this afternoon, and we wish all delegates ongoing enjoyment of the remainder of the program of IDC 2020. Thank you.
Thank you.